Welcome. My name is Sarah Dugan. I'm a social worker at the Blue Card, a nonprofit focused on providing assistance to needy Holocaust survivors. Thank you all very much for tuning in to our webinar on person-centered, trauma-informed care for Holocaust survivors. This webinar is specifically designed to train dental professionals in more culturally sensitive and compassionate ways of working with Holocaust survivors. Before we begin our webinar, I would like to briefly discuss what you can expect from today's training. Our speakers tonight are Dr. Alan Finkelstein, Dr. Gwen Cohen Brown, Dr. Eva Fogelman, and Dr. Maura Sassone. We will learn, through their research and their personal experiences with Holocaust survivors, how to best treat them in person-centered, trauma-informed ways. We will also discuss in greater detail exactly what person-centered, trauma-informed care means, and we will also explore tools, techniques, and advice in how to best treat them so that you will feel more comfortable working with both Holocaust survivors and other survivors of other forms of trauma. Before we begin our webinar, we would just like to ask you to answer these quick poll questions. Thank you very much for your participation. And now, I would like to introduce you to Dr. Radha Sumariva, who will officially introduce today's program.
So my name is Radha Sumariva. I'm a periodontist, and as some of you know, I represent two organizations here today. I am a co-founder and president of the Russian American Dental Association. I'm also a board member of Alpha Omega Foundation and board member of the New York chapter of Alpha Omega Dental Fraternity. There are a few organizations that made today possible, and I just wanted to briefly mention what they are doing. Well, firstly, Russian American Dental Association, we are 501c3 nonprofit organization, and we function as a professional society organizing various kinds of continuing education activities, as well as have community projects. And our two major community projects are oral cancer smoking cessation, where this project also has a very exciting and very popular kids branch. We have annual anti-smoking art contests and young musicians for Smoke-Free Planet movement. We would love to see you at some of our events, not hoping for all, but at least at some. And we would love for you to spread the word about all the exciting stuff we are doing. Another great project we have is Special Care for Special Needs, which raises awareness of the special needs community challenges and also helps overcome these challenges. And one of the projects that we partner with Alpha Omega as part of this is Building Bridges Conference. We are growing, and we are really looking forward to the third one next year. And again, if you have any interest in helping us putting together the conference or helping with raising awareness of special needs community challenges, please contact us. You know how to find us. Another organization that actually the organization that brought us here today is Blue Card. The mission of the Blue Card is to provide direct financial assistance to needy Holocaust survivors. The Blue Card is the only organization in the United States with the sole mission of aiding Holocaust survivors, which provides financial assistance on a monthly basis as well as for emergencies, such as medical and dental care. As part of the White House call to action to provide pro bono dentistry to Holocaust survivors, the Blue Card actually joined forces with Alpha Omega and Henry Schein Cares Foundation to carry out this crucial need. You're going to hear more about Alpha Omega and Henry Schein Cares program today. Again, for those of you who are dentists and dental hygienists, we truly need more volunteers in New York. So please get in touch with us if you are interested in volunteering for this wonderful program. Jewish Federation of North America, thank you for sponsoring this event, launched the Center for Advancing Holocaust Survivor Care on the fall of 2015 to advance innovations in person-centered, trauma-informed supportive services for Holocaust survivors in the United States. The Blue Card, one of many agencies awarded a grant by the Jewish Federation of North America, has further partnered with the Alpha Omega to develop a sensitivity training model for dentists and medical professionals in the industry. And I wanted to pass the microphone to Gail Schupak, Alpha Omega Executive Board Member, International Secretary, and also New York Chapter Treasurer.
Thank you, Rada. Bernice Edelstein, who is really the executive director of the Alpha Omega Holocaust Survivor Program, is unfortunately not feeling well today. So I'm actually stepping in for her. So I'm speaking on her behalf today, but also I'm speaking on behalf of Alpha Omega International Dental Fraternity. And if you're a dentist and you're here and you would like to join, we'd love to have you. A lot of you were probably members when you were in dental school. Maybe you didn't know that there is a life after dental school as far as Alpha Omega. There is, and we're international. We're all over the world. So I'm going to read what Bernice had written, if you would permit me, and then I'll introduce Dr. Fogelman. This is from her. Thank you, my friends and colleagues, for this opportunity to speak to you today. As many of you know, the Holocaust was the state-sponsored systematic persecution and annihilation of European Jewry by Nazi Germany and its collaborators between 1933 and 1945. Jews were the primary victims. 6 million were murdered. Roma and Sinti, also known as Gypsies, people with mental and physical disabilities, and Poles were also targeted for destruction or decimation for racial, ethnic, or national reasons. Millions more, including homosexuals, Jehovah's Witnesses, Soviet prisoners of war, and political dissidents, also suffered grievous oppression and death under Nazi Germany. Through our Days of Remembrance events, Alpha Omega, the International Dental Fraternity, seeks both to commemorate this tragic history and to reflect on the lessons it holds for our lives today. We also pay tribute to those rescuers who risked their lives to save others during the Holocaust, and to the American soldiers who liberated the concentration camps. It is not enough to curse the darkness of the past. We have to illuminate the future, explains Holocaust survivor Estelle Laughlin. On Days of Remembrance, the most important thing to remember is the humanity that is in us all, and to leave the world better for our children and for posterity. It is in that spirit that I invite those of you here today to become affiliated with Alpha Omega International Dental Fraternity and our Holocaust Survivors Oral Health Program. Started in 2015, Alpha Omega and Henry Schein Cares started a program to provide no-cost dental services for Holocaust survivors who are in need. Today, this program has provided dental services to over 500 economically vulnerable Holocaust survivors in 18 metropolitan cities throughout the United States and in Canada. Also, Canada has an incredible amount of Alpha Omegans, and they're very, very active there. There are still many survivors who need dental care, and we are hopeful that those of you in this room today will consider joining Alpha Omega and participating in this impressive program.
Thank you both. Before we begin with the presentations, we would like to ask our speakers to introduce themselves.
Hi, I am a social psychologist and psychotherapist, author, and filmmaker, and you will soon find out how I fit in with people in the dental profession. I have been doing work related to the intergenerational transmission of trauma since about 1976. I started the first groups for children of survivors, the first conference for children of survivors that then led to a whole movement of second generation. I then helped organize the Hidden Child Foundation, which gave hidden children their identity. And also I did a major research project on why non-Jews rescued Jews during the Holocaust. and started a foundation, which today is called Jewish Foundation for Righteous, where we were giving monthly stipends to, in its heyday, to more than 1,600 rescuers in 26 countries. I've written books. One of them is Conscience and Courage, Rescues of Jews During the Holocaust, and I wrote and co-produced a film that was on PBS called Breaking the Silence, The Generation After the Holocaust, and I'm working on a sequel.
Dr. Alan Finkelstein. I'm the CEO of a consulting group in healthcare called Bedford Healthcare Solutions. The immediate past chief dental officer at United Health Group. In honor of Dean Wolf from NYU, I'm on the faculty at NYU, and I sit on the board of 7 different dental schools. But more important than anything, my real true love and claim to fame now is helped organize the Alpha Omega Henry Schein Holocaust Program, and I serve as the clinical oversight and quality assurance for all Holocaust survivors. We make certain that it is a 3-dimensional program. Not only do they receive care from our beloved dentists in Alpha Omega, but they also have support through the Russian American Dental Association. There's no language barriers, especially in the New York area. We have so many former Soviet Union Russian patients. And the true, as we say in my wife's native tongue, the true French nachas is to see the outcomes. And these outcomes are measured on a patient-by-patient basis, something we in the insurance companies can learn from. That individual outcomes is what we should be striving for in this country. But this is more important that we as providers do what's right for our patients, no matter what type of coverage they have. This is proven by this Holocaust program.
Good evening. I'm Dr. Gwen Cohen Brown. I am an oral and maxillofacial pathologist. I have many of my colleagues, friends, former students here tonight, which is a pleasure to see that everyone has come together. I'm here representing the Russian American Dental Association, as I am president, or I have been working in charge of the director of the Smoking Cessation Project and Oral Cancer Foundation Project through them.
I am Dr. Morris Sasson. I have a general dental practice in Co-op City, where I have been treating Holocaust survivors for more than 20 years, mostly free of charge dental services. And I'm here to just talk about my experiences with the survivors, and somehow to help other dentists perhaps follow in the same path.
And he has a lot of patients, I can tell you, having referred
I
patients
have patients mostly referred through the Blue Card and Dr. Fogelman, and actually I started with survivors before the Blue Card or Dr. Fogelman, which I will talk about also. And thank you.
Thank you both. Dr. Fogelman will be speaking first, but before she begins, I would like to briefly explain a little about person-centered trauma-informed care so that we are all on the same page. Person-centered trauma-informed care, or PCTI for short, is a holistic approach to service provision that promotes the dignity, strength, and empowerment of trauma victims by incorporating knowledge about the role of trauma in victims' lives into agency programs, policies, and procedures. Basically, through PCTI practices, healthcare professionals can ensure that they will treat their patients in both culturally sensitive and compassionate ways that will make them feel at ease. And this will also help them avoid accidentally triggering them or making them relive their trauma in any way. We believe that PCTI is beneficial for both the client who has experienced the trauma and the healthcare professional who might possibly feel nervous or uncomfortable about working with patients who have been through a traumatic ordeal. It is our hope that this training will help you, in this case the dental professional, be more comfortable working with these clients, especially Holocaust survivors. And by helping you feel more comfortable, your clients will also benefit. And now that I have explained the basics of PCTI, here to explain PCTI care in greater detail is our first speaker, Dr. Fogelman.
First, I want to thank everyone for coming this evening to learn about trauma-informed supportive services and person-centered trauma-informed approaches. You're probably all feeling these days that all you hear these days is PTSD. Trauma here, trauma there, trauma everywhere. People are even complaining that they're being traumatized by the new administration. Enough already. But no, now we have gathered this evening to learn how to introduce trauma-informed care in our health practice. Yes, we are in a paradigm shift that's occurring in dental, medical, and mental health practices throughout the country. Of course, it's easy to understand why mental health workers and doctors have to know how to work with trauma. But why dental providers? Why should you, dentists, dental hygienists, and assistants care? Patients open their mouth, and after taking x-rays, you're pulling teeth, filling a cavity, doing root canal or an implant. Let's face it, how many survivors will be sitting in your chair who had gold teeth extracted without anesthesia in the concentration camps, or were tortured like Laurence Olivier in Marathon Man tortures Dustin Hoffman using a low-speed, dull drill without having administered anesthesia? Dentists, like other medical professionals, have to care because they don't want to re-traumatize a survivor patient. Before I describe trauma-informed care, I'm going to focus on who are Holocaust survivors as a historically traumatized group. What makes them different from other historically traumatized patients we may have, like Vietnam, those from Vietnam, Cambodia, Darfur, Bosnia, Rwanda, African Americans, veterans, unfortunately, to name just a few. So who are Holocaust survivors? And the definition of who is a Holocaust survivor has changed over the years. In 1953, when the German government was giving reparations to Holocaust survivors, their definition was any Jew who was incarcerated in a ghetto or concentration camp for 18 months. So that has changed over the years, both in terms of what the German government gives reparations to and how individuals personally define themselves. So the broader definition today is anyone is considered a Holocaust survivor who lived under the Third Reich or German occupation from January 30th, 1933 to 1945. So that means that Jews who were living in Germany from when Hitler became the chancellor are considered Holocaust survivors. In Austria, we're talking about March of 1938 when the Germans invaded. So that we look at a Holocaust survivor is any from the year that their country was invaded by the Germans. And not only if they were in concentration camps or in ghettos, we're including people who escaped, people who had false identification papers, people who were children. It is interesting that the German government never gave reparations to children because they felt that children did not remember anything, and therefore if they didn't remember and they couldn't say where they were or where they were hidden or who they were hidden with, if they couldn't remember, then therefore they could not possibly be traumatized by the experience. And that too, by the way, has also changed in terms of the reparations. But there are still Holocaust survivors who by this broader definition, who may not necessarily identify themselves as Holocaust survivors, even though they are living with the same traumas as those who do identify themselves. And so it becomes a problem when you're trying to figure out who is a Holocaust survivor, which I'll talk about a little later. There is a general fear, of course, going to dentists. Research shows that 1 in 7 Brits would rather endure a divorce than go to the dentist. I always wondered why that was so. Maybe they didn't have enough nitrous oxide. So if so many people are afraid of going to the dentist, why is this different for Holocaust survivors? For one, any sign of illness or weakness meant death or being executed. The natural setting of a dentist, standing over a patient in a chair, has many triggers for re-traumatization. When a survivor is confined to a chair in a dentist's office, he or she loses control. When a dentist gives an order, open your mouth, and the dentist then says, wider, it feels like an order to stand as if one is standing in a roll call. Or you're not standing straight in line. Or Arbeit schneller, work faster. The white coat or another medical uniform is another trigger of associations from the past. So you get the idea in terms of what some of the triggers can be when you have a patient who is a Holocaust survivor. In other genocides, the doctors and dentists did not play as significant a role as it did in the Nazi Holocaust. We have to remember that it was the doctors who were responsible for the killing. Everybody here, I'm sure, has heard of Dr. Mengele. And we have many survivors who remember how they might have had to, pinch their cheeks red so they will look like they were healthy when they didn't feel well. Or they had other people propping them, or people telling them that they're, if it was a child who was 13, they would say, make sure you say you're 16 years old. Otherwise, you're going to go straight to the gas chamber. And so it was the doctors who were the killers. They felt that they were doing the morally correct thing because they were getting rid of people who were responsible for spreading diseases because they weren't clean, because they didn't wash themselves. And so doctors, Dr. Robert J. Lifton, who had interviewed doctors in the 1980s, said that he didn't, I think he interviewed around 30 doctors. Not one of the doctors felt any guilt for the killing that they had done. And of course, you all know about the euthanasia program where it was doctors who wrote, somebody died of pneumonia, somebody died of heart failure, as a way of getting rid of the mentally retarded, the physically deformed individuals. And so this is why for Holocaust survivors, unlike some of the other historically traumatized individuals, it is the doctors and the dentists who can create a re-traumatization more than in the other genocides. So just like that, we all be on the same page. How is trauma defined? There is no universal definition of trauma. The Substance Abuse Mental Health Services Administration, SAMHSA, defines it as, and I quote, individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual being. Trauma is a word that was used first by Sigmund Freud, and he basically described that as any person who is undergoing a situation which is overwhelming to cope with. And in addition to the historical traumas, just to mention a few other traumas that are that we may want to think about as we're working with patients, which is experiencing or observing physical, sexual, or emotional abuse, childhood neglect, having a family member with a mental health or substance use disorder, experiencing or witnessing violence in the community or while serving in the military, poverty, and systematic discrimination. So I think you can see why when, we're talking about trauma here, trauma there, trauma everywhere, we're really covering quite a broad range of people who today are, have, traumatized lives. Now that we have the background and of the population that some of us are already serving, some of us may want to serve, I would like to talk a little bit about the how to healthcare workers can develop a trauma-informed care. Obviously, the first thing is awareness that traumatized patients may need special consideration. And of course, attending this workshop is a first step toward that awareness and the motivation to want to develop a trauma-informed approach to care. Implementing a comprehensive trauma-informed approach involves two things. It involves both an organizational and clinical practice changes that recognize the complex impact, not just on the patient, but also on the caregiver. Sandra Bloom, the creator of Sanctuary Model, has written, and I quote, "Trying to implement trauma-specific practices without first implementing trauma-informed organizational culture change is like throwing seeds on dry land." Now, the core principles of trauma-informed care. So we have patient empowerment, using individual strengths to empower them in development of their own treatment. Choice, informing patients regarding treatment options so that they can choose the options they prefer. Collaboration, maximizing collaboration among healthcare staff, patients, and their families in organizational treatment planning. So one of the things that you may find with Holocaust survivors, if they are referred by a therapist, if they are referred by their medical doctor, if they are referred by an organization like the Blue Card, self-help that is helping them, or some other social work organization, you may want to all be on the same page and have a conversation with the referring individuals, because chances are the survivor will be going around asking everybody, because of their fears, am I doing the right thing? What should I be doing? And so it is helpful to have consultation and collaborations with some of the other people involved with the survivor. And at times, obviously, it's if there is family, it may be a spouse or one of the children. Safety, developing healthcare settings and activities that ensure patients' physical and emotional safety. Trustworthiness, creating clear expectations with patients about proposed treatments entail, who will provide the services, and how will the care be provided. As you can see, we're talking about changing the culture of a healthcare setting so that the senior leader has to lead and communicate about this transformation process. Some of the changes in the organization is, one is, as I mentioned, one of the things you might want to do is even engage patients in, if you're going to do some kind of organizational planning, you might want to send out a questionnaire, or as patients come in, get some feedback from the patients about what they like, what they don't like about the practice, about the setting, And then training clinical as well as non-clinical staff members. For example, training the staff to greet people in a welcoming manner when they first walk into the building, which may help foster feelings of safety and acceptance. Initiate positive relationships. Now, I'm sure all of you know, but sometimes it is the secretary that ends up being more important as to whether a patient is going to come back or not come back, because they may have felt that the secretary was too rough with them, or didn't answer their question, or hung up the phone on them inadvertently probably, but the patient felt the phone was hung up on them. So that, again, you want to get everybody in your practice involved in this new awareness and the sensitivity of the traumatized individual. Creating a safe environment. Again, I'm sure that's something you think about not just for Holocaust survivors, but for all your patients, which is keeping the parking lot, the common places, bathroom, and exits well lit. Ensuring that people are not allowed to smoke, loiter, or congregate outside the entranceway. Monitoring who's coming in and out of a building. Keeping noise level quiet in the waiting room. Using welcoming language on all signature. Making sure patients have clear access to the door in the exam room and can easily exit. Okay, now what do we do in terms of the social and emotional environment? And again, I think this is this goes for everybody, which is the welcoming patients and ensuring that they feel respected and supported. So this is very important for Holocaust survivors who feel like victims. Some don't feel like survivors, they still feel like victims. And anything that sometimes said to them, they may feel that they're being, that they may feel like they're being disrespected. Maybe they're speaking with an accent and the secretary said, "What did you say?" In a way that, I don't speak a good enough English yet. Ensuring staff maintain healthy interpersonal boundaries and can manage conflict appropriately. And of course, when there is Holocaust survivors or anybody else who is anxious when they come to a dentist, one of the things that helps people ward off anxiety is getting angry. So they may say something, and a secretary may say something, and the survivor will start to yell and scream. And what is the secretary supposed to do? Or the dental hygienist, or even the dentist, when they're being screamed at, because obviously it's an unconscious thing that the patient is expressing their anger. How do you calm them down? How do you not get into and engage in this fight? Just in terms of talking about the interpersonal boundaries, which doesn't have to do with Holocaust survivors, although sometimes it may. There are Holocaust survivors who were sexually abused. And so, again, you're in a room. If you have a woman in a chair and you have a man, you may want to have a female dental hygienist there so that the patient feels comfortable. Most women who have been sexually abused in the Holocaust rarely talk about it. Very often, even their own family members may not know about it. Keeping consistent schedules and procedures. If a dentist is late or running late, which I'm sure happens all the time, again, you need to have something explained to the patient that you're going to be running late, or have the secretary say it so that they understand. I try to keep my 45 minutes or hour. Sometimes I'm a few minutes late, and I have had Holocaust survivors already knocking on my door that, how come I'm not there? I'm not there for them. This is very important, again, because most Holocaust survivors have been abandoned, whether they lost their parents, their siblings, their spouses, their children, and so when a healthcare worker is not there for them on time, it brings up for them feelings of abandonment. Again, this might be, at times it's a conscious thing for them, at times it's an unconscious thing, but they may start erupting. What's going on? Why am I not being taken? And that can create a whole raucous in the in the waiting room, so that even little things like that become triggers of the trauma that was experienced. Of course, it helps to offer sufficient notice if you're going to be changing anything, maintaining communication that's consistent, open, respectful, compassionate, being aware of how an individual's culture affects how they perceive trauma, safety, and privacy. How do I know if my patient has been traumatized or is more specifically a Holocaust survivor? Some Holocaust survivors you will find wear it on their arm with their number tattooed from Auschwitz. Auschwitz, by the way, was the only place that tattooed its prisoners. Some Auschwitz survivors do not have numbers because towards the end of the war, there were too many people coming in every day to register them daily, and so there was no time. Others came and were relocated immediately to some other place, and they too don't have numbers. Some survivors prefer to remain private about their past, and you may never know. A good idea is when you have a form to fill out for new patients about their medical history, you may want to include a few questions such as, what country were you born in? If not US, if not the US, when did you come to the US? If it's a European who has come after 1945 or between 1933 and 45 from Germany, and after 38, I mentioned from Austria, you can assume they are survivors of some sort. You do not have to be, you don't want to be intrusive. The dates from other countries who underwent genocide will also give you a clue. There are also trauma screening scores from questionnaires like ACE, and you can have the questions, you can have a question asking, are you a veteran of any war? If yes, which one? You can have an open-ended question at the end. Is there anything else the doctor or dentist should know about your personal or family history? And leave a few blank lines for an answer. Now, one thing that we often don't think about, which is preventing secondary traumatic stress in the staff. You may want to begin by training staff to about awareness of secondary traumatic stress, offering opportunities for the staff to explore their own trauma histories, supporting reflective supervision, where worker meets with a supervisor to discuss how they feel about their interaction with the patients. When you have a Holocaust survivor, and let's say they really irk you, but you feel, well, they're a Holocaust survivor, I can't possibly say anything. If it was, somebody else, I'd be able to say, keep quiet in the waiting room, or, but, you don't want to hurt the Holocaust survivor. How does that make the worker feel that they can't do what they're supposed to do? Or how does the secretary feel if the survivor is calling every day, can I talk to the doctor? Well, the doctor's seeing patients. And how do you keep your cool when the survivor is calling every day, are my x-rays ready? Or when is my bridge going to be ready? At times, you may want to allow a mental health day off for some of your workers, or possibly suggest yoga, meditation. And when you hire people, you may want to ask them what it is they know about trauma-informed care. So as I had mentioned, involving, particularly with the Holocaust survivors, you don't want to tell them what you're going to do. You want to discuss with them what you plan on doing, how they feel about it. So sometimes you may need to spend a little extra time explaining things so that they feel that they too are somewhat in control. And as I mentioned earlier, engaging some of the referral sources and partnering with some of the organizations. At times, it's helpful for patients to know that their trauma may be the cause of some of the dental problems they're having. For example, one of the things that you will find, and that's going to be recurring more as the years go by, is that many of the child survivors have very poor gums. And for you to explain that part of the reason they have that is because they had malnutrition during the most important formative years of their development. They may not like what they're hearing, but at least they will feel, gee, I didn't cause this to myself, and that's sometimes helpful to understand what is going on. So, in talking about all of this, I wanted to give you the numbers of what is it that we're talking about, and why is this so important, particularly in New York. We're talking about a fairly large population. Right now, we're talking about anywhere from 100 to 130,000 Holocaust survivors who live in the New York area. 25% of them are below the poverty level. Amongst the former Soviet Union population, about 50% are below the poverty level. Now, you may be thinking the fact that most of these people the youngest people today are 71, 72. So the majority of the population we're talking about are between 80 and 89. That's like about more than 80% of the people are between 80 and 89, and then between 90 and 99, you have about 20% of the people. So you're wondering, I mean, this is a dying population. How can it possibly be increasing in needing services? And one of the reasons that is the case is because we have the Russian population, which came here in the 1980s and 1990s, are a totally new population. There are also many survivors who, as I mentioned earlier, did not identify as being Holocaust survivors, and now they are identifying as Holocaust survivors. So that's again an additional group. And we've also had more recent immigrations of people coming from from other Eastern European countries. We now have people coming from France that are leaving France, who are also Holocaust survivors. So that you can see that indeed we are talking about a population that is going to need very intensive dental care. I'd say probably for the next 10 years or so. I think you can understand now the paradigm shift that we're experiencing now in the healthcare providers. Trauma is a public health issue that's transforming healthcare systems, and by adopting this approach, you will be doing a great service, not only to the Holocaust survivors, but to all traumatized patients, past and future. Thank you.
Thank you very much. Now, I am pleased to introduce Dr. Finkelstein, here to discuss elderly patients' needs and preventative care and treating them.
Let me start. Subject matter is really retooling dental health for the Holocaust survivor. So some of the objects here, we want to engage everyone in the room. That would be physicians, dentists, nurse practitioners, physician assistants, medical students, dental students, nurses, and other healthcare professionals to enhance the value, quality, and affordability objectives for the geriatric healthcare of the Holocaust survivor, to reduce the morbidity, mortality of the geriatric population by creating a paradigm shift. And that is based on something that we're looking in the insurance industry is reimbursing more for value than for volume. And that's the major shift. The Medicaid program in New York State has now shifted its emphasis to the insurers, the managed care organization, based on their outcomes, so that you will no longer be directed at a fee schedule procedure reimbursement. And this is where the creativity is going to take effect. We want to create a geriatric health home for the survivors by advancing a more integrated, holistic approach to geriatric health care. So basically what we're looking at is a two-dimensional overlay to create a dental home. This is so kind of sexy, dental home, medical home, but it should be a patient-centered geriatric health home, a health home, not a dental home, not a medical home, not siloed. And above all, the way we're going to drive that is one way. We're going to drive it through behavioral management to change the way we as practitioners practice dentistry today. And then we'll have a true healthcare professional. That healthcare professional will be reimbursed for early detection, not for just disease treatment and restoration. For care prevention, that's the key to it, evaluation and proper referral. Whole different way of reimbursing. So the challenges we face with the elderly population, physical disabilities, decreased sensory function, emotional disability, lack of means of transportation to get to the dentist, lack of truly trained professionals. So some of the coordinated efforts we have to address oral health needs, and a lack of a cost-effective delivery system. So I had to start paying for early detection, early treatment, even in the elderly. So basically we're stealing a Canberra model, caries by risk assessment model, resurfacing it in the elderly. And we're going to manage the patient on outcomes. Maybe it's time to think that we reimburse for non-surgical dentistry, non-invasive dentistry, palliative dentistry, see how the patient turns around their behavioral management, and then start with restorations. So the decay formation, minimal invasive treatment, there are ways to get into that so perfect for our Holocaust and all elderly patients. Okay? So geriatric care management should be a minimal invasive dentistry procedure for the Holocaust survivor, an evidence-based approach whereby the disease is controlled by the dentist and the oral health team. We have to see more preventive dental assistants working in the offices. It was very popular in the 60s, the time of the Vietnam War, and now it's time to bring back that person into your office. But the only way that's going to be viable is we in insurance start reimbursing for the wellness of that patient instead of the disease of the patient. Components of the approach are to conduct oral risk assessment, focus on early detection, prevention, monitoring, with surgical intervention utilized only as an end-state treatment. And then in order for this to work, I have to build a financial model to support that simple concept. And now we want to go to the precise linkage of systemic diseases. We hear so much about it. Is there a one-to-one ratio? It's something we have to take into consideration. If we have inflammation in the gums, in the gingiva, that's not a good thing. So let's look at some specific diseases. In diabetes, of all the results, and there's some wonderful research, and I hate to call it research, but studies of paid claims, that when patients have dental intervention, the cost of care in certain oral systemic diseases goes down. Diabetes is probably the best of all, because we're going to go on and show you this, that the precise linkages of diseases is still unknown. There's a synergistic effect. When oral infections arise and go untreated, seniors face heightened risk factors for diabetes, cardiovascular disease, and above all, respiratory. Okay, so in diabetes, periodontal disease, back and forth, periodontal treatment is needed. And when we do periodontal treatment, we have an improved glycemic control. And how do we know that? Just measure the hemoglobin A1C. And we can come back with better by just that intervention. The cost of care goes down astronomically. So something I wrote with a friend of mine, Bert Edelstein, that was published in the New Republic. And basic dental care is not particularly costly. Unfortunately, it is generally restricted to its own silo, separate from the rest of the American medical care. Sun Dental, blah, blah, have argued for a stronger focus on prevention and a greater integration of medical and dental concerns. So, Eleanor Roosevelt, the future belongs to those who dream. We're going to dream that we get a system that everyone can have good health care based on solid business economics and reimbursing for the proper outcomes instead of just billing for the sake of increased revenue. And that's about it. Thank you.
Thank you, Dr. Finkelstein. Now, I am pleased to introduce Dr. Cohen Brown to discuss the importance of oral cancer screenings.
Thank you. So what we're going to do is go through some of the current trends in epidemiology and the diagnosis of oral cancers. So I am officially the director of RADA's Oral Cancer and Smoking Cessation Program. I'm also a full professor at New York City College of Technology. As I said before, I am an oral and maxillofacial pathologist. So this is one of our basically our advertisements. This is the calendar of event for April, May, and June. This was from 2012. We have been meeting annually to do these free oral cancer screenings all over the tri-state area. Probably I've been involved in it since about 2005. They have been written up in Russian newspapers as well, and we are very actively reaching out to the community, to the Russian-speaking community, as well as to anybody who is interested. These are not only for Russian-speaking patients. This is for anybody who is interested. Okay, so let's just talk about some basic oral cancer statistics. There are 30,000 new cases of oral cancer in the United States annually. This has not changed. Of the oral cancer, squamous cell carcinoma is the most common type of oral cancer. We can see melanoma intraorally. We can see perioral lesions. We can see salivary gland pathology as well. We can certainly see things like melanoma in the perioral skin. One thing that is really interesting is that the 5-year survival rate has remained at 50% for the last 50 years. Think about that. Our 5-year survival rate is awful. And part of the reason that it is so bad is that, well, there's two reasons. One is that for those people who are not going to dentists, for people who are going to physicians, and for the physicians in the audience, I apologize, but how many of you have gone to a physician where they've gone basically from the lips to the pharynx and they haven't looked at anything in between and they're just basically going right back and they're not really doing a thorough oral exam? The other issue is that the intraoral carcinomas that we're seeing, especially the later stage ones, are really going to be seen at the base of the tongue, floor of the mouth, right where the two meet. So how many people, when they're doing their oral exam, intraoral exams, are really wrapping the tongue up in gauze, taking the tongue and literally trying to remove it from the person's mouth in a very kind and gentle way? But you really have to do it. The other issues are things like field cancerization. So when I'm teaching oral cancer, one of the things I'm talking about with my students is like when you're drinking alcohol, it doesn't just affect one part of your mouth. If you're smoking cigarettes, it's going to go both into the upper GI as well as the lower GI, as well as go into the oral cavity. So you're going to be having the same potential pre-malignant effects that are going to be attacking multiple areas, and that concept is called field cancerization. And that's going to result in not just one but multiple primary tumors, so that if you have a patient who has a primary oral carcinoma, if they do not stop drinking and smoking, 31% of them will then, within the next 5 years, will develop a second primary tumor. 17% of them will develop a second primary tumor even if they do stop drinking and smoking. So having a conversation about both alcohol as well as smoking is really important. The advanced stage of the disease at the time of the diagnosis. So when you think of lip lesions, they're really easy to find. If you're looking at base of tongue lesions and floor of mouth lesions, they're not so easy to find. So if you're not really looking and you're not really getting in there, the way that we're diagnosing them, they're being diagnosed at a later stage as opposed to like an early stage. Frequently, early lesions are either ignored or not adequately identified by clinicians, and therefore you're getting delayed treatment. By far, tobacco is the most likely etiology of most oral cancers in the United States. I'm going to go with cigarettes first, then pipe and tobacco. Marijuana, that's getting up there, okay? We're seeing an increase in amount of marijuana use. And when you're talking about older patients who are going for alternative pain methodology, even though it is not officially legal in this state, we still have medical marijuana that is creeping in around us, and these people are smoking. So it is something you want to talk about with your patients. In terms of etiology, alcohol is not really a pure etiologic factor. It is a potentiator. It's going to take something and make it worse, so that if you look at alcohol sitting on top of tissue, it's going to cause a dryness or a dehiscence of the tissue. It's going to break apart the intercellular bonds, which is going to allow for better penetration of the intercellular carcinogens. A prior history of having oral cancer is actually a huge etiology. So if you've already had cancer once, the likelihood is you're going to have it again. It's something to consider. And human papillomavirus, wow, we are seeing a major increase in that, okay? The American Dental Association and the Oral Cancer Foundation recommend that an oral cancer screening be done on every new and recall, or they might be calling them recare patients now, okay? The goal of Healthy People 2000, 2010, and 2020 were, at minimum, to get 20% of the patients in this country to have oral cancer screenings annually. This has not been met. Do you want to know how pathetic that is? In the Healthy People 2020, which is what we're going for right now, do you know what they're looking for to have as their ultimate high-end goal? 20% of the patient population, which means that 80% of people in this country are not having oral cancer screening annually. Okay, and only between 14 and 18% of those of dentists are doing screenings on each patient. And what I would like to say is, to do a good oral cancer screening, to do a head and neck exam, it really only takes about 2 minutes. You can talk to the patients, you can tell them you're giving them a massage, you can just tell them you're looking whatever you want to be looking for. There's a lot of ways of doing this, and there's a lot of ways of making the patient feel non-invasive, not uncomfortable as well. Oral cancer screening or detection involves both checking for disease in a patient who is currently symptom-free. Case finding is actually the term used for application of a diagnostic test or procedure to a patient with an identifiable lesion in order to establish a diagnosis and to bring the patient to treatment. Early detection of oral cancer actually is rather important. It reduces patients' morbidity and mortality. It decreases the likelihood of advanced or invasive tumors, so that if you can catch a tumor that's a stage 1 tumor, the 5-year prognosis is probably about an 80 or 90%. If you catch a tumor at a stage 4 diagnosis, you're talking about a 20 to 30% 5-year prognosis. So the earlier you see them, the earlier you find them, the better off the patients are going to be. So it's going to improve both short-term and long-term prognosis. And the earlier that you find these lesions, it's going to require much less aggressive treatment with fewer complications or potential complications. Okay, other benefits of early diagnosis of oral cancer is basically you've got less invasive treatment, better treatment outcomes, and higher survival rate overall. Your barriers to early detection. So this is some of the things you want to think about. Well, why aren't people getting early detection? Well, it's asymptomatic. You know how they always call cancer the silent killer? It's called a silent killer because it doesn't hurt. It doesn't hurt until it's gotten involved into the lymph nodes. Once the lymph nodes have gotten involved, or you start seeing an inflammatory response, then you're going to start getting pain, but it's not going to be pain from the tumor. The reason that tumors do not cause pain is that they infiltrate the peripheral neural setting, so that you're actually killing the peripheral nerves. Therefore, they're not transmitting pain. Okay, so the way you start getting pain is once you start getting an infection or the tumor gets quite big. Barriers to early detection, malpractice. People are not doing this regularly. And by the way, you are responsible. You are responsible for doing an oral cancer screening. I would personally, on a personal level, I would recommend just including that as a note. When you are writing your progress notes or whatever it is that you performed an oral cancer screening, just write OCS so everybody knows what it means. Or actually, everybody doesn't know what it means. So if you do use letters in place of words, someplace in your office, you have to have that sort of listed and printed, and so that everybody knows that if you come into your office that OCS means oral cancer screening. Just make yourself safe. Economics, people are not coming in because they don't have dental insurance, and there's a public unawareness of oral cancer. Basically, what I would like to say about oral cancer screenings is that a head and neck intraoral, extraoral exam is still the standard of care. It is what the American Cancer Foundation is saying. It is what the Oral Cancer Foundation is saying. It is what the American Dental Association is saying. Use your hands. Use your fingers. Look and see what you can find. I mean, honestly, I can't tell you how many patients we find things. And as my dad, and I will just say this for my dad, for the last 30 years of his life was receiving holiday cards every year from patients whose lives he saved. And that's because he looked, okay? I mean, it wasn't that he would, I mean, I can't tell you, if people are coming over to me and say, well, I've never seen anything. I was like, well, look, you gotta look. I mean, you really have to look. And you can do this very effectively in a small amount of time. The emerging technologies right now are complementary and are not meant to replace a thorough visual and physical oral cancer exam. That's it. Okay, thank you.
Thank you very much. Our final presentation is Dr. Morris Sassone to talk about his personal experiences in working with Holocaust survivors.
So I just wanted to talk about my own experience with Holocaust survivors over the last 20 years. My involvement with Holocaust survivors started with my own parents, who were survivors from Greece, and not that much is talked about the Greek survivors. Not that many people know about that, but 87% of the Greek Jewish population was lost during World War II. So actually, my work with Holocaust survivors started in my own practice before actually working with the Blue Card. And I can actually trace it back to one couple, Barbara and Irving Schweitzer. And they were, this was about 28 years ago. I just listened to their stories. And this is one of the things I want to mention, that you should listen to their stories if they want to tell you. If they don't want to tell you, fine, but you need to listen. Listening is one of the most important things. So I remember listening to her, and she actually was in the Lord's Ghetto and saw somebody jump out of a burning building, okay? And they both needed dental care, and I just decided, you know, this is my chance to do a mitzvah, and offered free dental care. And from there, you know, I started working with the Blue Card and seeing many patients and offering free dental care. And I got to listen and hear their stories. I don't know if I was going to talk about that, but I know it's getting late. And, okay. You know, the survivor population is dwindling, but there are still a lot of survivors out there. And I actually had a survivor, Dr. Fogelman referred to me, who had dental implants in her 90s, and who played the mandolin at Lincoln Center. And she passed away last year, but she was
99.
99 years old. So you might think that, survivors, how many survivors are left? It's just not the case. So some of the other survivors that I have seen, they share their nightmares, and the children actually share their nightmares also. So I just have to say that you really should listen to their stories if they want to tell you their stories, and be a mensch. And your staff is very important. My staff is here actually, Maritza, and it's so important. It really is so important that when a patient calls, a survivor calls, they want to be called back, they want to be reassured. I mean, I can't emphasize enough how important that is. You think that it's all being a dentist and a healthcare professional, but it's not the only thing. It's not the only thing. And so some of the survivor stories. I had a survivor who tirelessly fought the German government for reparation. I had a survivor who was told that something must have been wrong with her to survive, as if she was damaged goods. I have to tell you, but our patients have been very kind and appreciative, just to show caring and respect their dignity. And that's what I want to impart for you. I'm not capable anymore of doing free dental work. And so I'm kind of like passing the baton. I'm getting a little older. And I just would like to see that more dentists are doing this, taking care of Holocaust survivors and even giving free dental care. And I know the Henry Schein is actively involved with this. And so that's my story.
Thank you very much, Dr. Sasson. We hope you have enjoyed our training so far and have hopefully learned a lot about the different person-centered, trauma-informed practices to help treat Holocaust survivors. Here are some brief points to help you summarize PCTI. Now, as a healthcare provider, it is important to always have awareness of your clients. Be aware of the large role dentists and doctors played in the Holocaust. And be aware of the fact that your well-intentioned actions and statements may be misconstrued by clients who have not forgotten the actions of the dentists and doctors in the Holocaust. Always be mindful of your clients that may be survivors, and take care in treating and interacting with them. Empower and educate your clients whenever possible. It only takes a few minutes to explain what you are doing, but it does a lot to ease their anxiety. And it also helps them feel more in control of what is happening to them, as if they have a choice, rather than feeling as though this is being forced upon them as happened to them during the Holocaust. Use empathy. Empathetic behavior and comments go a long way towards making your client feel understood, valued, and like their concerns are acknowledged. Listen to your client's verbal and nonverbal language. Some clients may not verbally express discomfort, but may make it clear in their actions or their body language. So it's crucial to be mindful of any client who seems uncomfortable in any way and take a moment to reassure them. Some nonverbal actions that express discomfort include looking away, fidgeting, sitting all the way in the corner of their chair, biting their lip, or even just taking a while to respond. And of course, if they verbally express any feelings of discomfort, make sure you are listening to that and are mindful of that as well. And also, don't just look for signs of their discomfort. Make sure you're also listening to their positive language and mannerisms. It's always good to be mindful of what makes them feel at ease so that you can continue doing or saying the same things that are making them feel more comfortable. Also, remember the importance of patience when working with Holocaust survivors. You might find your clients' reactions to certain events confusing and even frustrating, like if they start to cry because the receptionist tells them that you are unavailable. Just remember that they have been through a traumatic event which changes the way they view things. They might have increased anxiety, a fear of abandonment, anger of what they've experienced, just to name a few. Well, for instance, To you, you missed their appointment because your other client had an emergency. But to them, once again, they've been abandoned by someone who promised to take care of them, just like their loved ones did during the Holocaust. So just do your best to be patient with them and explain what is happening so that they understand. You can always use your staff meetings and supervision time to vent if you need to, but try your best to show the patient only patience and understanding. And finally, remember that person-centered, trauma-informed care begins the second the client pulls up to your office. The first face that they see, usually the receptionist, can have a negative impact on them if they feel that they're being judged or misunderstood in any way. So be sure to train your entire staff in PCTI practices. Thank you all for attending our webinar on person-centered, trauma-informed care. We hope you found it insightful and have learned a lot on how to work with Holocaust survivors. This webinar was actually comprised of a few different presentations from another JFNA-sponsored event that the Blue Card held a few months ago. If you would like to view the original event in its entirety, you can download it on our website, which is www.bluecardfund.org. We will also email you the link to the original event and this webinar within the next few days as well. Please also feel free to visit our website if you are interested in learning more about our different volunteer opportunities. And please also feel free to visit the resources listed here for additional information on how to get involved and also to learn more about different dental practices. Now, we are about to begin our questions and answers segment, but before we do, we have a few final poll questions for you. Thank you very much, as always, for your participation. Now, we are ready to begin our questions and answers segment and answer any questions you have. Okay, so let me see here. So the first question here was for Dr. Eva Fogelman. Someone was asking, what should they most be mindful of when treating Holocaust survivors in a dental office?
Can you hear me?
Hi, we can hear you.
Can you hear me?
Did you hear my question?
Great. Yeah, I heard the question, sure. So the first thing to be mindful about in treating Holocaust survivors is just the greeting, a very friendly kind of greeting so that the Holocaust survivor feels welcome, they feel that you're present for them. I would say that that is the first thing. The other thing to be mindful about is that if you know that a patient is a Holocaust survivor, don't begin asking them questions about, you know, where they were during the war, what happened. You wait for the survivor to give you some kind of signal about whether they want to talk or not talk about their experiences. They're there to be treated for their dental problems, so that you want to, one, make the person, the patient at this point, feel very comfortable with you. You also want to make sure that you explain to them what you're doing, the options that they have, so that they don't feel that, you know, you're controlling the situation, that decisions are being made jointly. And if they're not ready for the treatment that you're proposing, I would give the time, let the patient know that indeed, you know, they don't have to decide today unless obviously it's an emergency where a tooth has to be pulled. And they can think about it, they can ask other people, and they can come back, they can call you if they have any other questions. So again, the Holocaust survivor does not feel that that you're in a way dictating what the treatment is. That they're involved in the treatment plan, and that you are patient and want to work with them.
Right, and following up from that, we also had another person asking, if you could talk a little bit more about things that could accidentally trigger survivors.
Yeah, well, I would say that let's say a patient came late, and the secretary says, "Oh, you're late. I don't know if the doctor can see you." So that it begins with the secretary who is there to be very patient, to be very calm, because otherwise they may feel, because they are coming into a medical environment where a doctor's uniform, in many offices, the dental hygienist also is wearing a white coat or some other color today. The secretary may also be wearing something. So right away, there's a feeling that the survivor gets triggered with, he's going to be, or she is going to be losing control. When I mentioned in my remarks, you tell somebody, open your mouth, or wider. These are instinctual kinds of things in terms of how a dentist talks, but in this case, again, you want to do it in a very gentle kind of manner. It will help me if you open your mouth a little wider, or please close your mouth. It's going to help me work better on, this part of the mouth. So do speak to the survivor in a more gentle kind of way, because otherwise what it will trigger is, what they heard from Mengele, Dr. Mengele, or some other doctors, that they heard, move faster. And that, by hearing particular kinds of commands from a dentist, those associations come back of what it was like to be confronted with a doctor during the years of incarceration.
Right. Thank you, Dr. Fogelman. So we do also have a question here for Dr. Cohen Brown. The question, first of all, is how can we learn more about oral cancer screening?
Hi, can you hear me?
Yes, we can hear you.
Okay, great. Super. There are certainly articles in the journals. I know that JADA, the Journal of the American Dental Association, has a lot of information. If I get to toot my own horn for a second, I did a video with the National AIDS Education and Training Center on how to do a head and neck exam, which is about 12 minutes long. It's very detailed. It goes through the different stages of how to do it and what is considered to be normal. On a personal level, what I would recommend doing is reading a little bit about it. You can look at the Oral Cancer Foundation. They have a lot of really good information. But if you want to look up the video, if you look me up, which is Gwen Cohen Brown, DDS, and video, I've done 3 videos that are up on some national websites, and the first one that should come up is how to do a head and neck exam. In terms of what we learned when we were in school, I think everybody basically learned the same process. What I would also say is that it doesn't matter what order you do any of the head and neck exam in, as long as you do it exactly the same way every single time. So that way you won't forget anything. I hope that answers the question.
I think that answered it very well, and we can also include a link to your video when we send the whole recording of the webinar out as well, so I think that will help people.
That would be super. Thank you so much.
Oh, you're very welcome. And Dr. Sassone, you also have some questions. Are you able to hear us?
Yes.
Okay.
Hello?
So hi, we can hear you too. So
Okay.
the first question you had is, somebody wrote, you seem very passionate about your work with survivors. Are you still working with survivors today?
Yes, I am still working with survivors, but very few.
Okay.
And yes, but I am still working with survivors, yes.
And they also asked a follow-up question for you. They said, how did you get your clients to be so open with you?
Well, first of all, I let the patient bring it up. I let them talk, and if you have a kindness to Holocaust survivors, they will open up if they want to, and they did. Some did not, and the ones that did were very appreciative of somebody listening to what they had to say, and that's it. I mean, you have to just basically be very kind. Even your facial expression matters. How your secretary, how the person who works for you treats them. Maritza, who works for me, used to take survivors out to the excessive care. She especially walked them. And all these things matter. All these things matter in terms of how they will see you. It's not only your dental work. Of course, we talked a lot about the dental work, Dr. Fogelman and Dr. Brown, but you basically have to be a mensch and be very kind.
Absolutely. Thank you very much. And Dr. Sumariva, somebody asked, how can I get involved in volunteering with RADA?
So the program actually that was described as supported by Russian American Association, but is sponsored by Alpha Omega International Dental Fraternity and Henry Schein Cares Foundation. Would be more than happy to explain how to get on board. We do need volunteers, so truly appreciate the question and truly appreciate your support. I guess if you would provide my personal email, I would be more than happy to follow up on the details on how to join the program.
Absolutely. We can send an email out about that as well for everybody. And then as a follow-up question for that, somebody also asked about CEUs.
Sure. Yes, so I guess we will have the list of attendees, and we can email certificates of 1.5 credits of continuing dental education credits.
Okay, thank you.
And for those of you, just one addition, for those of you who are HED members, please make sure to submit it directly to HED because it goes towards your fellowship program.
Thank you very much. Dr. Cohen Brown, we have another question for you.
Sure.
Somebody asked if you could speak more about the technology. I think they mean regarding oral cancer screenings as well.
Yeah, the emerging medical technologies, right. There are a number of emerging medical technologies that are on the market right now. Some of them are better than others, but none of them have actually gotten a seal of approval from the American Dental Association or the Oral Cancer Foundation. Not saying that some of them are not better than others, and I'm not going to say which ones necessarily are the best right now, because they all have very good points and they all have not so good points. Some of them are very easy to use, but the ones that are incredibly easy to use don't necessarily have reproducible factors. I think if you're looking at a program to purchase for the office right now, which I'm assuming is one of the questions that's being asked, is which one should we get? What you want to look for in a program is something that requires little technical work to do, that you can take photographs of, because oftentimes what happens is one person will do a smear, or they'll do a fluorescence in the office, and then when they're referring either to a periodontist or to an oral surgeon to have a biopsy done, and the place they're referring to does not have the same exact setup, sometimes it's hard for the referring doctor to get the correct information to the person who's going to be doing the biopsy. It's not always transferable. So anything that comes with the ability to take a photograph works. Sometimes you have to consider things like if you need to be doing this in a dark room, does your office get dark? Some of them are really light-based, so that you have to be able to pretty much cut off all the light while you're taking the picture, which I think could also be a little bit traumatic for people as well. Some of them have rinses that are somewhat don't taste really very good. And some of them are being done in conjunction with a biopsy or a cytologic smear on site. So in terms of my feeling is at this point doing a really thorough head and neck exam visually, as well as using bimanual palpation and really taking your time is still the best technique. At this point in time, there are emerging medical technologies that are on the way, but none of them is really what I would call infallible. And part of my concern also has to do with how much people are charging for them. So some of the units themselves are thousands and thousands of dollars, and so that people are automatically getting oral cancer screenings with these very fancy devices that they don't necessarily need.
Right. Thank you so much. I think that was very informative. I hope that helped the person who asked that.
Me too.
And then we have one more question. This one's for Dr. Fogelman. This person said, do you have any recommendations about outreach? How do we get Holocaust survivors to come to our office? And I guess anybody really can answer this one. So how would we get Holocaust survivors to come to our office?
Well, you can certainly, give your name to the blue card, and when survivors call and say that they're looking for a dentist who is sympathetic to survivors, there will be a list of dentists that they can choose from. They can also call the local Jewish Federation that also has support system for provide support for Holocaust survivors, and let them know of your availability to work with Holocaust survivors. I would say in the New York area, there would be self-help, but throughout the United States, it would be the Jewish Family and Children's Services that is the main organization. There are also local Holocaust organizations. There are also Holocaust centers. If you look at the United States Holocaust Memorial Museum, they have a list of all Holocaust organizations, so you may take a look at that and see what is in your local area. You may want to go and meet with the director of a Holocaust Center, where you have survivors who are often speakers there, and they have programs for survivors. And so that would be another way for people to know that you have a particular empathy and understanding of the needs of Holocaust survivors in dental treatment. We also have the American Gathering of Holocaust Survivors and American Gathering of Jewish Holocaust Survivors and their descendants, and you may want to look them up and let them know that you have a particular interest in empathizing with the dental needs of Holocaust survivors. So I'd say these are a few of the ways in which you try to reach out to that particular community.
And of course, joining the program, Henry Schein Care's Alpha Omega RADA program, treatment of Holocaust survivors, would help as well. As a matter of fact, we run annual conference where we bring together different agencies as well as providers. So if you can email again your interest, with your interest, then we can put you on the mailing list and include you and send an invitation for this upcoming conference, which is going to be in December.
Okay, and we'll email some information about that as well. So just in case somebody missed that, we'll have it all emailed to you. And I think that's all the questions we have been given. If there's nothing else, then I guess that's the end of our webinar. Thank you all so much for coming. Thank you to our presenters. You were amazing. And if you have any other questions later on, you can send us an email. You will also have the webinar that's been recorded emailed to you in the next few days, so you'll have that as well.
So thank you so much, everybody. We really appreciate you being here.
And thank you very much to you, Sarah, for organizing it and doing such a great job.
Yep. Thank you, Sarah.
Thank you.
You're very
Thank
welcome,
you so much,
everyone.
Sarah.
You're very welcome. Have a nice day, everybody.
Okay, bye-bye.
Bye.
Bye.